examination, and also estimates the indirect effect of intervention. So there are broadly three types of cluster trials to choose from. One is the conventional cluster randomized control trial that we all know. So here on the first left top graph, we have 6 clusters, and the horizontal line is the timeline. So what we see is in the first left upper graph, we have 3 clusters which have been randomized into the intervention and 3 into the control arm. We do a baseline, we give the intervention, and at the end line we evaluate the outcome. The next is a CRCT with a baseline period, which is B here. And here we do a baseline in amongst all the clusters, amongst all the 6 clusters. And after this baseline, we randomize the clusters either into an intervention or into a cluster. So this also allows you, to do some sort of pilot testing of your intervention, to adapt, to contextualize, to modify, to improve your intervention to suit the community. Next, we have stepwise design so that every cluster provides before and after observations, and every cluster switches from the control to become exposed to the intervention after a set period of time, but not at the same time. And here in this design itself, we talk as a control period and as an intervention period, and not control arm or control clusters and intervention clusters. So Dr. Mahapatra will be explaining more about this today. And then we have a stepwise study where we include the transition period. So one cluster which is at the control arm, you give some time to adapt it or to convert it into an intervention arm. Because again, going back to my example of smart health, where it includes training, capacity building of the healthcare workers, it takes a bit of time, and this design allows that time to be accounted for. So how do you define a cluster? The clusters can be defined as geographical clusters. It could be communities already there. We know villages, we know towns. It could be administrative units, wards, census, enumeration blocks. It could be arbitrary geographic zones. Take a map, put grids, and say this is my cluster. It could be institutional clusters, which could be schools, healthcare facilities, the primary healthcare facilities, hospitals, clinics, the workplaces, offices, factories, etc., or it could be smaller clusters, households. Say, for example, when you are taking nutritional intake, dietary intake, So we know that in one household, that all the individuals, they will give similar kind of reporting. So we might want to use that household as a cluster there. In my example, again, going back to smart health, because that was a strategy to provide end-to-end care, enrolled healthcare workers to the primary healthcare doctors, and the primary healthcare doctors were at the highest level where the intervention was delivered. So the clustering, we took the primary healthcare facilities as the clusters for our study. Now, coming to the practical aspects of the cluster randomized control trial, what are some of the concerns that we have and that we need to take care of when we are doing a cluster randomized trial? Everyone must have heard about the ICC, which is the intra-cluster correlation coefficient. So when we are talking of clusters, we need to remember we are talking of 2 components here. One is the clusters, and one is the people within those clusters. So the peoples within those clusters, and if I can take an example of village as a cluster. So the people within those clusters, they are very similar to each other. So the amount of correlation that exists within those individuals versus the correlation that exists between each cluster that we have taken in our study.
In a very concise way, you have presented the main principles of cluster randomized trials in a very simple manner, and I think thank you for that. What we have done is we have asked participants to pose their questions in the chat box. We will try to address these as we move on or at the end of the seminar. Because we are running a little late, so what we'll do is we can move on to our next talk, and then at the end, if we can give about 5 to 10 minutes to address these questions. If that's not possible today, we'll save the questions from the chat, and then we can always try to address them later also and get back. So thank you again.
Sure.
I now move on to our next talk on step wedge design. The expert for this session is Dr. Amrendra Mahapatra. who is a scientist F at the Regional Medical Research Center, ICMR, RMRC at Bhubaneswar. Dr. Mahapatra is a senior researcher and has done his PhD in medical anthropology. He has worked in the field of epidemiology, especially in the field of tuberculosis, malaria, filariasis, and nutrition in India. He has served in different states working for the Ministry of Health and Family Welfare and has multiple publications in international and national journals. So I now invite Dr. Mahapatra sir to please go ahead with his talk.
Thank you, everybody, for patiently listening. And after Dr. Parveen has given a very vivid description, I will be giving a brief outline of the step-wise design. This is a research study design. This is followed in certain conditions. Generally, any health research or any research or social research the aim is to represent the universe. The universe should be represented properly, and the results we can generalize the results. These are the two aims of this. And once we propose our study, at that point of time, we should have what we aim for. The aim of the study should be very clear, and then only you can achieve the objectives. Objective aim is, suppose there is a relation between aim and objective. In an aim, suppose I want to go to Delhi. The objective is the way, how many options I have, by air, by road, by walking, by water road. So whatever the ways are, these are the objectives will give you the ways how to reach the mean, the aim. These are the means. So we should clarify all these objectives. There should not be many objectives, one or two objectives, and aim should be only one in any of the studies. So when the study is in a large population or large community, at that point of time, other clinical study designs may or may not fit in better. But presently, the step-wise design is designed in such a fashion where you can implement the study in a stepwise fashion. Not at all, because the universe you cannot study, it is not possible to start the implementation in the entire universe. So suppose your universe is a district or is a block, then it is difficult. So what you do is you segment them into clusters, as Dr. Parveen was giving you the example of how to make clusters, village-wise, block-wise, GP-wise, or PSC-wise. So I will be sharing, in this regard, I will be sharing my experience with step-wise design during my studies in the effect of nutritional effect among the tuberculosis patients in Odisha. In this study, we have taken 19 DMCs. So district microscopic centers, we have identified 19, and among them, whoever was positive, we are enrolling them and giving them free ration with the support from the Tata Trusts. So we conducted this study for 2 years, over a period of 2 years. That is 12 months, the study, the preparation, and other report writing and all other time period. So the total study period was only 12 months. So in these 12 months in 19 DMCs, we have made some steps. So that each DMC, so let's share the screen better. So I'm sharing a screen now. I hope it is visible.
Yes, sir, we can see.
Yeah. And most errors we incur in all the clinical trials as a result of poor planning. In a hasty condition, we start and there are fancy statistical methods cannot rescue the study flaws. we don't plan it carefully, and out of impulse, we select a easy statistical method study design to follow, which later on at the right time of writing report, we don't know what we are hiding, we know better. The objective of clinical trials is to establish an effect of intervention. So to establish any effect of intervention, what is the universe of intervention? If the treatment effects are efficiently isolated by controlling for bias and confounding factors and by minimizing variations within the cluster and variation within the cluster also. So it should be looked into. Key features of clinical trials are used to meet this objective are randomized, possibly with stratification. Adherence to the intent to treat principle should be followed. Blinding and prospective evaluation and use of a control group should be followed with the help of a true statistician help. Compared to other types of study design, case control studies, cohort studies, case reports, randomized trials have high validity, but more difficult and expensive to conduct. In any research, we should keep it in mind that the manpower required, the travel money required, and what is the expense we are doing it, and at what cost. How to minimize it scientifically without impact to the results. That is most important. So there are four phases in any clinical trial. The first phase is, we all know these four phases, I think. I should not go into deep all these things, isn't it? So first phase is done within a limited enrollment of 20 or 30. Then phase 2 is a trial conducted investigation, dose response, optimal dose calibration. Then phase 3 is the last studies confirm efficacy of any intervention. And the phase 4 is trial carried out after registration of an intervention. Last trial conducted by companies and marketing and all those things. And the effect versus reaction management should be seen at each page. And we know the alternative hypothesis is always there. Then intent to treat, these are all analyzed as randomized. Then null hypothesis is claimed to often that an investigator desires to disprove. See the alternative hypothesis, because if the null hypothesis is proved, then you are gone. Then the power. These are some definitions. The power is in certain in the calculus, while calculating the results, we use the power. Suppose at what trial design or how much it will be superior to the placebos, your drug will be superior to the placebos, or your alternative treatment, how it is going to help the community in comparison to the old drug. All this will depend on the power. Then we make two errors, type 1 error and type 2 error. Type 1 error is probably if rejecting the null hypothesis when it should not be rejected, false positive. That is, in superiority trial, this means the probability of incorrectly identifying a treatment effect when indeed a true treatment effect does not exist. So when we do this type of mistake, the type 1 error, then type 2 error is probability of failing to reject the null hypothesis when it should be rejected, that is false negative. Type 2 error is the complement of power. In superiority trial, this means the probability of failing to identify a treatment effect when indeed a true treatment effect exists. So this seems to be very complicated in reading and making you understand, but these are very simple. The null hypothesis, what you are doing with the null hypothesis, are you rejecting it? Then it is false positive. If it is, you are not rejecting it and expect, then it is false negative. You remember false positive and false negative, then we will discuss. This is a study when evaluation of effectiveness of cost effectiveness of the community delivered integrated malaria elimination model in Myanmar, the protocol for an open step-weight cluster randomized control trial. This is published in BMJ 2021. So, and we use this, I will say my experience also, as I told you, that in the effectiveness study, effectiveness of nutrition study among TB patients, which we conducted here in this center in Odisha. So there also we applied this stepwise design. That is to understand it in one sentence, that is called phased implementation. When the implementation is phase-wise, is particularly useful when it is not feasible to provide the intervention to every individual or community at once. So the intervention is rolled out sequentially to the trial participants, either as individuals or cluster of individuals over a number of time period. The order in which the different individuals or clusters receive the intervention is determined at random, and by the end of the random allocation, all individuals or group will have received the intervention. Here, the statistician should allocate this randomization and the PI should be blind in this factor for better results. And this design is evaluating the effect of intervention that have been shown to be efficacious in a more limited research setting and are now being scaled up to the community level, and also useful to evaluate temporal changes in the intervention effect. Data analysis to determine the overall effectiveness of the intervention subsequently involves comparison of the data points in the control section of the weights with those in the intervention section. This here I am explaining how I have taken 5 clusters, and in each cluster 4 DMCs were placed. In the first cluster 3 DMCs, in last cluster 3 DMCs are there because we have limited while participants are being enrolled. Intervention in cluster 1, the other 4 clusters will be enrolling the control group. After every 3 months, the next cluster will begin enrolling the patients to the intervention until the 4 clusters are enrolling for the control group. The enrollment of the study will stop in all the clusters when the logistics of stepwise design trial pointed title. So the logistics of stepwise design trial is shown as below. You see, here I have taken step 1, step 2, step 3, step 4, and step 5. 5 steps are there. And the intervention period is 12 months, for which I have taken a division of 3 months each. 3 months, 3 months, this is 12 months table. And in this first, suppose you go to row 1, step 1. Step 1 is step 1, you see the white portion is the control group. Okay. And the black portion here are they are enrolling here. Okay, they are enrolling here. And when we go to step 2, they are enrolling here the control. They were doing it, but after 6 months they will be doing the intervention group enrollment. So similarly, the things will go on like this up to step 5. So the statistical analysis, you see the sample size is determined. First we determine what will be the number of cases we will be getting per DMC and per year in the entire district. So in that district, what we found is from the 214 annual status report of the RNDCP TB India report, that we found the Gajapati district is 73% as compared to the national average of 90. We assume that our food supplement by improving the adherence rate, the treatment success rate will increase to 73 to 90%. In this study, there are 19 direct microscopy centers and average 5 cases per month at each DMC that records 285 new smear positive cases per quarter. Thus, approximately we will be having 1140 per year. Out of this 1140, how much we need? This is the same clusters how we have done the out of the guidelines. The intervention will be rolled out among the 3 clusters in 3 months interval. The outcome is sputum smear are measured on the study participants in all the clusters at every time period. Hence, measurement of outcome takes place at each step in the weights. Each cluster provides data point in the control and intervention condition, allowing each site to act as its own control. That is the previous slide or previous. That is, you see, each step is having black row and white row. That is, they are the study arm and the control arm is there in every step. In step 1, step 2, step 3, and all. In all clusters, we have study arm and control arm. Next. So, assuming an intra-cluster correlation of 0.5, 95% confidence level, 90% power, and 20% of refusal or loss to follow-up, the required sample size is 703 patients over a period of 1 year. But we are having 1400 patients. So the cluster will be randomized into one of the 5 dates to start the intervention time, and hence the sequence of units and clusters that will start the intervention in each period is determined by random allocation. The randomization occurs before the start of the trial. Then after the data collection, we are measuring the sputum smears at every quarter of all the patients enrolled as control and as in the study arm also. And besides that, in the study arm, we are taking their height, weight, and all anthropometric measurements, hip circumference, chest circumference, mid upper arm circumference, and all this, and we are calculating the BMI, fat mass index, and all. And these are carried out at a monthly interval. And we are also going to the house to visit the consumption level, to examine the consumption level, and also to give a nutrition counseling to the patient and its family. The primary outcome is bacterial conversion rate. Comparison to the same in the pre and post intervention period will be reported. Baseline data collected from the first time period will be tabulated by order of implementation, grouping the cluster into 5 groups of 19 clusters. This will include conversion rate, mean age, sex, and other process measures. In the primary analysis, conversion rate will be modeled using mixed effect logistic regression with random cluster effect, allowing inclusion of baseline risk factor such as comorbid disease, etc., and adjustment of a fixed time effect between intervention period. It is most important to make this adjustment fixed by the statistician to minimize the confounding factors in the society or in the within the study period, study population. We will examine the adequate of our randomization and include any DMC level variable unbalance at baseline in our final model. The patient level covariates to be included in the model will be finalized prior to the analysis. Team to event analysis will be carried out using a Cox proportional hazards model with fixed random efforts. The study outcomes can be increased in the cure rate. The because you see, we are giving the food supplementation to the family of a TB patient. So the study outcome obviously is increase in the cure rate and increase in the body weight. Thus, when we calculate the BMI should increase. These are the outcomes we expect. The proportion of patients and amount of gain in the body weight, BMI, lean body mass, and fat mass from pre-treatment level, change in quality of life, and in addition to that, we are also conducting WHO BREF QOL scale. We are following that. The change the quality of life from baseline and age assessed using the WHO timeline and time to return the normal pre-treatment and post-treatment. Definition as per the study outline. So these are you have to reframe all these definitions according to your study. What is cure, what is treatment completed, when you think, because what we took is initially sputum positive patients we have taken who has completed treatment and had negative sputum on 2 occasions, one of which was at the end of the treatment. So this is as per the RNDCP guideline and we followed that. Then treatment complete. Initially sputum smear positive patient who has completed treatment with negative sputum smear at the end of intensive phase, but none at the end of the treatment. This is treatment completed. Next. And there's a treatment failure. Failure means treatment failure. Any TB patient who is smear positive at 5 months or more after starting treatment, that is a failure. Loss to follow-up is a patient who has not taken the anti-TB drug for 2 months or more consecutively after starting the ATT. Then diet. The patient who died during the course of treatment, regardless of the cause. Here you should be very careful. In our study, what happened? In the intervention arm, we found there are 5 deaths, and on postmortem of the data, we found that these are all old cases. They have left the drug 2-3 times before, and they came for enrollment in lieu to get the ration free ration to the family. So we could ethically we could not deny them also. They were positive patients and they were suffering, so we gave them. And since due to their old age, 5 patients were died. So hence, I will caution here that when you enroll a patient, in that enrollment status, you should write whom we are enrolling and why, whom we are not enrolling. And in that old enrolling, you should have a caution for enrolling the old patients, especially in TB studies. And transferred out a patient who has been transferred to another TU or district, and his or her treatment results outcome is not known. These are all. Then you have to go to your software to get the result. Thank you all. This is all about in 15 minutes I could give you an outline of the stepwise design. And if you have any questions, please carry on. Thank you.
Thank you, Dr. Mahapatra. I think again, you have also in a very concise way presented the major points to be included in a stepwise design using an example of your own study. So I know that we have overshot our time a little bit, but if it's okay with both Dr. Praveen and Dr. Mahapatra, we can just take 2 questions if that's all right. The first question is for Dr. Praveen. So the question within the chat box was that what regarding cluster randomized trials, how can you represent the results and are characteristics of clusters to be measured and reported in the results? So Dr. Praveen, could you just maybe respond to that? Sir, you're on mute. Can you please?
Yeah. Sorry, I just responded to that. So it's going to take a bit of time to explain the characteristics, the covariates, and the analysis plan. How do you take into account ICC, and then ICC can be again within clusters and intra-clusters. So yeah, so maybe I can share some resources, or I can share some documents which clearly explain this, or one of the presentations that I can do and I can share it with you if that's useful.
Okay, great. Thanks a lot. And the second question is for Dr. Mahapatra, that there's a question that is a stepwise design, including transition period, same as a crossover design?
As I mentioned in my beginning of the talk, we should not confuse ourselves while conducting a study or initiating a study, first of all. Secondly, we should not jump into many statistical lure. We should not be lured by statistical methods, because there are several methods for the study. But what is best? Why you want to crossover? Crossover design is entirely different. Okay, that doesn't fit here. So crossover, what you want to crossover design? Crossover design is not stepwise. Stepwise design is very simple. The transitional period, what Dr. Parveen has given, you see, that is a time to cope up. Time to cope up with for the study participants and for the workers also, and for the logistic arrangements of the study. That is the transition period. But this is not same as crossover design. Crossover design is something different. I should not talk about that.
Okay, thank you, sir, for that clarification. We just have one request before we close to both our speakers, expert. Is it okay for you to share your presentation? Because some of the participants have been asking if you can share your presentations. Dr. Praveen, is that okay with you? Okay, thank you. And Dr. Mahapatra? Yeah. So you can mail it. You can mail it to us, and then we'll. Yes, you can mail it to us, and then we'll share it with the participants.
In this screen also, I am ready.
Okay, great. So thank you very much, and I hand over to Dr. Aparna for the closing remarks.
Thank you to both our esteemed speakers for tackling these very difficult topics on randomized clinical trials. And thank you for all of you who have attended, for your patient listening and for your interest in these topics. And we hope to continue these webinars on a monthly basis. And if any of you have any ideas as to what part of RCTs, what specific issues that you want to discuss and want to learn in details, you can always contact us, and we will get the relevant speakers for that. Thank you so much for this.
Thank you.
Thanks for the opportunity. Thank you.
Thank you.